So today I'm talking about synoptic reporting, and I'm Michelle Longpre. In case you don't know me, I'm one of the residents. I'm a 50th resident here.
Everybody knew you.
So if you're like me a few weeks ago, or well, I'll say a month ago, I didn't know what synoptic reporting was. I'd never heard of it before. But it's sort of a new and upcoming term that you're probably going to hear a lot more about in the future. And probably by the end of this talk, you're going to be sick of hearing the word synoptic. Unfortunately, I have no disclosures. Maybe someday. But there are some slides that are adapted from the Canadian Partner Against Cancer. So by the end of this talk, I'd like you to know what synoptic reporting is. I'd like you to know where we are in the development of bringing synoptic reporting into surgery and pathology here. I want you to understand the benefits of it as well as the issues associated with it. I'd like to discuss how you can bring synoptic reporting into your office and into EMR. But throughout this, I want you to focus on the take-home point, which is that even though self-regulation may not be fun, it's a lot better than externally imposed regulation. So let's keep that in mind. So you're probably wondering, what is synoptic reporting? Well, I think it's almost easier to describe what isn't synoptic reporting, and that's narrative dictations. So this is just an example of a narrative dictation where it seems more like scut work than actually creating an important document for communication and collaboration. This again is an example of something that's not synoptic reporting. This is narrative dictation, and I think in this situation there may be a little bit of important information missing. Just a few things, and that's often a common problem with narrative dictation. Another issue with a lack of important information where someone's trying to be very efficient, and this is a very fast, efficient way of doing a few radical prostate dictations at the same time, but they may not convey the uniqueness of each case and each person. And then there's the other issue of non-pertinent information being incorporated. So, it is nice to know what size of suture you use, but that's not important to be put in your dictation. And if a seminal vesicle explodes in your face, you just have to move on. And even if you're awesome, it's not something to put in your dictation. And what happens after you create one of these lovely narrative reports is they go to your staff person. And they're reading your dictation and thinking, what the? It's just not very helpful. And then the same report then goes off to the GP. This one happens to be my mother. And they have no idea what happened in this operation. They don't know why the operation happened. They don't know what to do next with this report. So this is an example of non-synoptic reporting or narrative dictations. So what does synoptic reporting look like? This is an example from Alberta. So synoptic reporting in Alberta is one of the areas that's coming out in the forefront, and it's a web-based type dictation where there is no narrative. You just click through a series of questions, and through that, this is for breast cancer, all the important information from the operation is gleaned out, and none of the non-essential information is there. And I'll get more into the details of this shortly. But the goal in the future is to take this synoptic reporting or web-based reporting in pathology, surgery, as well as lab data, clinical data, and imaging data, and have that all brought together into a Canadian registry where we can improve our outcomes and focus on patient-centered care. So that's the goal in the future of synoptic reporting. That's what I'm talking about today. So it's a structured method of reporting an operative note. It should be there will be a national standard for synoptic reporting in both surgery and pathology. And it's a way of capturing data at a point of care method where it's efficient and fast and cost effective. Now you might be thinking, I've been doing narrative dictations for years. Why would I change? So even though change sometimes is difficult, I'm going to discuss why in this situation it may be beneficial to move on to something different. So this is a paper looking at the issues with narrative reporting, and this is from abdominal perineal resections. And you can see here some things we're very good at reporting narratively, like how we close the abdomen. But when it comes to things like the operative details or metastatic assessment, we're lacking most of the information. Only 17% of the reports had information on the metastatic assessment. So overall, in a narrative report, and this has been shown in a number of different studies, we're around 50% of the information, of the important information is included in our dictations. Now when you compare that to synoptic reporting, so when they brought synoptic reporting into different centers and compared the two, you can see here on the right-hand side, these are some of the percentages of important information that was gleaned from a narrative dictation. And then you compare that to synoptic reporting, which achieves almost 100% completeness. On average, through a bunch of studies, they're missing sort of 1% of information or 2% of information in most of the synoptic reports. And so this is talking about the surgical side. The pathological side and the pathology side of synoptic reporting is also very, very essential. And they're also missing a lot of information, which I was surprised at some of the numbers. And this is looking at pancreatic tumors. And I was surprised to find that in this report, only 11% of the specimens actually reported on margin status. And you can see that in synoptic reporting, they're up at 95%. And again, only 50% of the reports for pathology, you could actually glean what pathological stage this tumor was, whereas when they switched to synoptic reporting, they were 100% on this. And this is again showing the same thing in just to sort of beat the point home, that when you compare narrative reporting to synoptic reporting, there is a significant difference in the ability to gain the appropriate information from that pathological specimen. So just on the pathological side of things, they're perhaps in some areas in the States a little bit ahead of us in synoptic reporting. So they have the College of American Pathologists that has produced a checklist for all different types of tumor sites. Now this checklist is quite long and it's difficult to work through. It involves a lot of text entering. So Rochester has come up with a new method of more of a dynamic web-based way of pathologists reporting their data. And you can see here this type of report where they would select the organ that they're looking at. It would take them through and it would be very difficult to miss anything, as it prompts you to put in all the different areas. And this type of report would be able to be available immediately and also go directly into a database, so the data collection would be done immediately. So far I've shown you what synoptic reporting is and the fact that it gives you a complete picture of what happened in an operation, what the pathology looks like. But in order for this to be taken up by surgeons, we need to show that it has some benefit for patient and patient care. And one thing that's been shown in literature time and again, that if you adhere to guidelines, you improve patient outcomes. So let's see how our ability to follow guidelines are. And one of the areas that's been looked at is breast cancer. I'll come back to breast cancer quite a bit because it's been looked at a lot in synoptic reporting. But in 1998, they brought out new guidelines for breast cancer and tried to improve the number of patients who were having breast salvage surgery. And before the guidelines came out, sort of 1995 and 1998, of the patients who were able to have breast-saving surgery, only about 50% had it. And you'd think after the guidelines came out there would be a big increase. However, the uptake was quite poor, and only a few more percent of surgeons were offering this to their patients. And we're not much better. I mean, these are British urologists, so you can take it with a grain of salt. We might be better than them, but when looking at the uptake of mitomycin C, you can see here only 7 or 8% of surgeons in Britain were offering as a first-line treatment for CIS or for high-grade T1 tumors, whereas mostly they were using it for multiple tumor occurrences or patients that had multiple locations of tumors. So there is some issue with the uptake of guidelines, and that's one of the areas where synoptic reporting is going to be beneficial in improving our adherence to guidelines. And so here's another example of some of our issue with adherence to guidelines. They were looking at the use of neoadjuvant chemotherapy in muscle-invasive bladder cancer, and I've really looked at how we did before the guidelines and how we did after the guidelines. And as you can see here, you could definitely see there's an improved downstaging of tumors with the use of neoadjuvant chemotherapy. So you think the guidelines would create quite a good uptake to near 100%. And there was some improvement in our referral to medical oncology, but it was still quite low. And the hope would be that after the use of synoptic reporting, where this would help to bring into surgeons' minds on a daily basis that they should think about referral, that would help increase this use of chemotherapy. So in order to address this issue with adherence to guidelines, Alberta came out with the WebSMR Synoptic Computerized Reporting System. And I'll just show you this here. So this is, again, their example So as you can see here, if you were going to click through this, it would prompt you to ask, is there a contraindication to radiotherapy? And so it would help you to guide the surgeons along to the appropriate management based on the guidelines. So they would ask you, is this person candidate for breast-conserving surgery? And so by doing that, it would help patients, help surgeons think about it. And when they added this in, they got up to 84% adherence to guidelines, up from 55%. So it was quite effective. And just to flick back here for a second, even better in colorectal surgery, before they brought in synoptic reporting, there was only a 20% adherence to doing the appropriate resection of a total mesenteric excision. And after synoptic reporting, they got up to 98% adherence to guidelines. So this has a big value for adherence to guidelines and thereby better patient outcomes.
Michelle?
Yes.
In Alberta, do we have any idea how many surgeons adopted this? Like, what was the compliance or acceptance rate within Alberta of this process?
It was 84% of the uptake.
84% of surgeons
of the ones that they introduced it to uptook it, and that was just in the pilot project. I'll sort of come to that a little bit more.
What percentage of surgeons in Alberta actually started doing this, participating?
84% of the ones that they introduced it to in the initial pilot project. But I'll come to that a little bit more. So just to show you where we're at so far in this talk. So we know what synoptic reporting is. We know the difference from narrative reporting. We now know why it's better than narrative reporting. And we know how it can improve our adherence to cancer guidelines and thereby improve motivation. So now we need the motivation to change. So how are we going to do that? So the Canadian Partnership Against Cancer has come out with a data warehouse where they can collect the information across Canada for patient outcomes. So what they've created is sort of an opportunity for both, it's an opportunity for surgeons and for patients essentially in order to improve the amount of information we can get from our operative reports, from our pathological reports, and feed these back to our surgeons in order to improve outcomes. And so this is the pilot project that's been started in Canada, and it started back actually in 2007. And we weren't involved in this. It was Alberta, Ontario, Quebec, and Nova Scotia. They were involved in the initial pilot project, and mainly breast cancer, colorectal surgery, ovarian, and head and neck, which is why I've been talking about breast cancer quite a bit. And this was a partnership that's been ongoing up until now, and I'll discuss the next phases that we're coming to. Also in pathology, they've been doing the same thing, and over the last 5 years, they've been taking the checklists from the American College of Pathologists and bringing those into standards. And they're a bit slower in the uptake of this, but the plan is to get this across Canada over the next 5 years. So this is sort of what you were asking, Dr. Masterson. So when they implemented this pilot project in Alberta, they had about an 85% uptake of surgeons using it, mostly in breast surgeries where they started, as well as the other areas there. And they found that people were quite surprised with the results for how well it did uptake and how well it was used. So they actually found that 80% of the reports were done in less than 15 minutes, many of them done in less than 5 minutes, and a good proportion of them were done actually before the patient even left the operating room. So it's a very time-effective way of getting the information out there quickly. And so 80% of the reports were done within 24 hours, and I know I can say I don't get my reports often done within 24 hours, so this would definitely improve the speed at which I get my reports out, which I'm sure would make Dr. Black happier. So this is the next phase, is phase 3 and 4, and that's where prostate cancer comes in. Oh, we're no longer connected to the meeting. Do you want to reconnect? I'm sure no one else is listening out there. Okay. So we're bringing into prostate cancer here, and in the next little bit, I'll also talk about how we brought that into prostate cancer and some of these indicators, which are the quality indicators that they're coming up with. So in order to start phase 3 and 4, they brought a bunch of urologists from across the country and sent them all out to Winnipeg. I'm not sure why they chose Winnipeg. I guess there's nothing else to do but talk about synoptic reporting. And their job was to create a template. And this is some of the areas that they were discussing, trying to fill these out and determine across the country, could we agree on these different areas and what would be important in a prostate, in a radical prostatectomy surgery. And so these are some of the areas they were discussing. And we hope to have that template out soon. And the overall goal would be to, in the future, you would have synoptic data from a biopsy as well as clinical data, and that would be incorporated with your operative note. That would be distributed to GPs and hospitals immediately. It would then get added to the pathological data, which would then go to this Canadian database. And from that, it would allow you to have direct feedback that you could then use in order to improve your next operation. So now, this might look simple enough, but it is quite difficult to get a bunch of surgeons to agree on how to do their operations and what things are important. So we'll discuss some of the issues with synoptic reporting. Now, one of the issues was what to include. There are mandatory as well as optional items, and each province had an opinion on what should be important and what should be included in it, what things should be mandatory. But some people didn't quite realize that we need to all sort of agree on this. The other issue is trying to choose what quality indicators we could use. How do you decide how we're going to measure how good we are, how we're doing, just based on our operative report? So these are the quality indicators. And what this takes is just takes basic data and turns it into useful data. So we would have a measurement data point, and this would be turned into a metric that would then be turned into an indicator that we could use in order to feed back to surgeons. So an example would be the number of infections, and that would be your infection rate. And then you get feedback as to what kind of infection rates you're having in the hospital over a certain time period, and comparing that to other centers across the country. And this would allow you to adapt your methods based on that. There are a number of different areas of quality indicators that people have discussed, one of which was from Queen's, where they felt that in radical prostatectomy, one of the three sort of quality indicators would be transfusion, length of hospital stay, and whether a nerve sparing was done. Some other areas that they looked at when they were in Winnipeg they thought were maybe more important were more complication-based. So again, blood loss, rectal injury, and extensive node dissection were some of the three areas that came up as quality indicators that people could feed back to determine if they were achieving success. And these are some other quality indicators that would be useful in the pathological setting as well as in the clinical setting. So now the problem is, when you talk about quality indicators, a lot of surgeons sort of feel like this little guy. And that's not what we're trying to achieve. The objective of synoptic reporting is not to point the finger, but in order to sort of improve our outcomes individually. But there are some issues with this. A lot of surgeons are going to think, can we trust this data? Is one person's lymph node dissection the same as another? Is one person's nerve sparing the same as another? And this is one of the issues that has come up as to whether they can trust the data. And if a surgeon can't trust the data, they're not likely to adopt it, and it's not going to motivate change. One of the other issues is, how do we then interpret these differences? And I thought this was sort of an interesting point from one of the papers. Now, if you said, these are 10 hypothetical surgeons who each treated 50 patients. Now, if you were looking at these 10 surgeons, who would you refer your friend to if you're looking at these recurrence rates? And I think a lot of people would say, well, surgeon 1 and surgeon 3, I think. They seem like the best people that I would send them to. But you'd be wrong. They're all the exact same. With only 50 patients treated, there's no significant difference between any of these. And sort of to drive the point home a bit more, if you just look at surgeon 3 and surgeon 6, in order for those two surgeons to actually have a significant difference in their recurrence rates, they would each have to do about 1,000 surgeries in order to gain the power.
The biggest difference is who they're operating.
Mm-hmm.
I mean, it's a problem with outcomes related to nerve sparing.
Mm-hmm.
Not to do nerve sparing, your positive margin rates. It depends upon your case mix.
Yeah, and that's one of the things they would do a better job. In narrative reports, it's hard to get that information out. Often the stage of the patient is not there in that narrative report. So the goal would be that in your report, web-based report, you would have that information. Is this patient impotent before surgery? Are they a high-risk cancer? And so that information would be in there, and you'd be able to compare across the country of those selected patients and maybe do a better job of that as opposed to just looking, did you nerve spare or not? What your margin rates were. But it's one of the things that people are going to be concerned about. One of the other problems or concerns that came up was sort of unanticipated consequences or sort of perverse incentives. So sometimes policies can be well-meaning, but they can be counterproductive at times. And one of the issues people think is, well, if people are looking at my margin rates, maybe I will start sending my high-risk cancer patients to radiation oncology, even though those are the ones who might benefit most. So it may lead to the wrong type of incentives. So those are some of the issues. So there's a nice paper from Memorial Sloan Kettering that looked at sort of changing the paradigms. And there's two paradigms. They both lead to better patient outcomes. One is the old paradigm, which is the name and shame style. It does lead to better outcomes. Perhaps you just move patients from the worst surgeon to the better performing surgeon, but that's not what we're trying to achieve. We want to go to the new paradigm, where we look at continuous quality improvement. And so we take those surgeons who might be subpar in certain results, and we bring them up to the rest of the group. And that's the idea. And Memorial Sloan Kettering felt that this is best done with private reporting and not public reporting. And the Cancer Care Ontario guidelines have been doing this with margin status in Ontario. And they did sort of a similar thing where they tried to bring everyone up to the same level and improve everyone's margin status across the province and in the small communities without people feeling as though they're having the finger pointed at them and being forced to drive everyone into one center. And they did do quite a good job with this. So I think it's important to realize that the goal is to promote this new paradigm, and in order to bring all the surgeons along and increase everyone's level to improve outcomes, and not just to push people off the road, but in order to really create appropriate change. So I'm going to change gears a little bit. We've talked about the operative data, we've talked about the pathological data, but really what that leads to is how do people doing in their outcomes, and how do we get the outcomes data? How do we bring out how they're doing in terms of continence and impotence and oncological outcomes? And that's where this trifecta comes in. And I don't know if you ever bet on horse racing, but in order to get a trifecta, you have to guess the win, place, or show. So if you miss one, you don't win the big money. And so the idea is you need to have oncological outcomes first, then continence, and then potency. If you're missing oncological outcomes, well, it really doesn't matter if you've achieved continence or potency. And again, if you achieve oncological outcomes, but they're not continent, that gentleman in diapers may really not care about his potency. So the goal is to achieve all three. And it can be difficult to measure these outcomes. And that's one of the issues, is knowing what your outcomes are. We know we can quote larger studies from things like Memorial Sloan Kettering, but do we know what our individual ways of assessing this are? I think there's sort of 4 ways of doing this. You could be at VGH and have a large team of research assistants helping you. You could have a web-based data entry like Alberta. You could do EMR-based data entry, which I'll talk about, or you can just hope you have a really good memory and you just sort of remember how your patients do. So a lot of people don't have the access to a large research team, and a lot of people don't have a good memory. So I'll talk about the second and third options. So web-based data collections. Now, I don't know if you've heard of CASES, which is from Memorial Sloan Kettering. They've come out with this where they have created this web-based style where in your EMR you're able to compilate all the post-operative outcomes. Now this is a bit of if you look at this online, you can go through a demo, and it's pretty tedious, and they actually ended up requiring their own research assistants just to input this data. So this one I feel is a bit over detailed, but it does give the surgeons a day by day. They can look at how they're doing compared to all the other surgeons, and not naming people, but just seeing where you're at in different areas, such as recurrence-free survival. So the other option is doing it through your EMR. And now we have Accuro here, and a lot of people use Plexia. So I decided that I started working with Plexia to try to create a way for community urologists to record their own data in a easy, streamlined way that wouldn't take too much time. So I've been working with them to create a way of pulling this data out quickly and efficiently. So let's say, for example, this could be Accuro, this could be Plexia, or any other EMR system. You get a task back about a patient. Let's say they're having issues with continence. You could then click on another link, and it would take you to your outcomes. And you could quickly click through a few links that could be adjusted to how you want it, and record some outcomes for that patient. And it would be recorded under the date and the person's name. And then let's say you later see that same patient in clinic and you have some more results. You can then go back into your outcomes, click in a few more things. So this way you can, as you go, you can quickly and efficiently and in your own workflow pull out the data from each patient. Now one of the issues is how do you best measure functional outcomes? That's difficult. When you look at studies on potency or continence, half the time only a small fraction of the patients that they looked at were allowed to be included because there's so many, this patient was impotent before surgery, this patient was incontinent before surgery, or this patient wasn't candidate for nerve sparing. So this paper here has looked at a better way of scoring where we can include all the people that we operate on, into it so that we can get the best of numbers to compare against our colleagues and to help us improve. And this I thought was a nice way of looking at it, where you can compare, let's say this is survival, so these are the trifecta: survival, continence, and potency. And all patients would be included in this, so whether they were impotent beforehand or they couldn't undergo nerve sparing, or they have a good shim score without AIDS or a good shim score with AIDS, and again with continence and survival. And then this would be able to be output into graph style, where you can compare to your colleagues and see how you're doing and what areas you might need to improve in. And so your goal is to end up in the top left-hand corner. So if your patient started out being continent and potent, you could be up in this top right-hand corner if you achieved success. But even if the patient was impotent pre-op or couldn't undergo a nerve sparing, you could still achieve success by being in the top left-hand box there. And so this way, you can include all your patients and compare to your colleagues and see how you can improve. Now, just as I'm coming to the end of my talk here, I wanted to take a brief second to ask to get a little bit of feedback. So let's say you have EMR, whether it's Accuro or whether it's Plexia. I'm curious to know how long you think you would spend on each patient pulling out this data. And maybe just with a show of hands, you could tell me how long, if you think you would spend 5 minutes per patient pulling out data. Anyone spend 5 minutes? So while you're seeing a patient, would you spend an extra 5 minutes in order to collect some data on that patient?
You're talking to them anyways, aren't you?
You're talking to them, but let's say instead of just writing your note, you're also inserting a little bit of data at the same time in a pop-up box. And I'm curious to know how long a surgeon would spend when they're seeing a patient, if it would add.
But Michelle, the parameters you listed there are physician obtained information, not patient generated or validated questionnaires.
No, they're.
We have validated questionnaires. You mentioned shim.
Yes.
So the patient will have filled out the shim score, so that just has to be transferred in. You're not asking him.
Exactly. It only has to be transferred in.
So you're just asking how long does it take to transfer the score?
Yes. And would you take 30 seconds to click a few buttons to transfer that in?
It depends how the internet is running that day.
Yeah. So that's, if anyone has any feedback, at the end, if you'd like to let me know how long you think you'd spend and whether you think you'd give a few seconds. Yes?
What happens at our office is they fill out a questionnaire, validate the standardized questionnaire, it just gets scanned in, so it's just there as a PDF.
But then that wouldn't be able to generate outcomes for you. It wouldn't give you any data. And so you'd have to go back and go through all of your patients. Let's say you decide, I want to look at all my patients from the past. So you have to go back, go through all of them, input the data. And so that would be fairly time consuming. So the idea would be, at the time that you're seeing them, you'd be able to pull out that data and directly put it into a database through Plexia.
There is an alternative, isn't there? I mean, if you give everybody an iPad type thing, the patient just puts it in, and it goes straight into the database from there, and then you wouldn't have to do it.
That would be ideal, and there are systems where you can actually have them. Some EMR can be linked to websites, so they can fill it online, and then it can be directly inputted. But we're not quite there yet in a lot of areas, and this may be a step before that. It would be nice to have the patients do that. So I'd be interested to know if this is something people would use.
A patient fund a cubicle that will go in our waiting room that we will have web access to encourage patients to do that.
Yeah.
I think it's important for the shim and everything else for the patient to put it in. But, hey, so you can pose your question. If we're having to do this in our office or in the OR in the OR, how much time would people? Yeah.
So how much time would people spend? 5 minutes. Would anyone spend 1 minute? 1 minute?
No, Michelle, I'm way more than a minute.
You spend 5 minutes?
It's going to take several minutes to put all that data together. Meaningful data. I mean, you can.
I mean, you should buy an apple.
Yeah. Maybe, or give the patient an iPad.
Yeah. Would you spend 5 minutes, or would you say this
you can do
just
it while
too long?
You're talking to the patient. I mean,
exactly.
We can multitask.
Yes. Yeah. So
I would hope that most people spend at least 5 minutes with their patients.
Well, we hope, but it would, perhaps it would add an extra minute or 30 seconds.
Might add a minute or two. So.
Who would say 30 seconds is the max I would spend on this? Okay, so maybe about a minute or so. Maybe 30 seconds start to be.
Somewhere between 1 to 5.
30 seconds.
30 seconds. It's only a few clicks, and you can also edit. You'd be able to edit it ideally so that you could shrink it down to make it less data entry, or you can make it bigger if you wanted to create more data if you felt like spending more time.
I wouldn't spend more than a minute. You're asking us how much we were willing to spend.
Yeah, spend
Not
in
How
extra.
much do we think it would
In
take?
addition
Yeah.
to what you usually
And then
do.
how long would you be willing to spend, and then ideally we would then tailor it to create something that would be that would only take 1 minute.
A minute.
A minute.
You would tell the resident to spend 10 minutes.
10 minutes talking to the patient while I fill in this form in 1 minute.
Yeah. I'm sure you can get a medical student to do it. So.
What about the question of cumulative time? I mean, this is your one encounter, 30 seconds with the database entry.
Mhm.
You're coming back to it again and again and again as you get the path reports and everything else. What about the cumulative time this would require? For
Well, see, I think it would sort of only be, say, 30 seconds. So maybe one time you see them, you open it up and you just click on one box. It might take 5 seconds. The next time, maybe another 5 seconds. Or perhaps you wait until you're seeing them preoperatively and you fill it quite a bit of it at one time.
So I just say, at the end
Yeah.
of the day, how much time
Mhm.
would a surgeon spend per patient
Yeah.
completing the database?
Mhm. And perhaps at the moment there isn't as much motivation to do it, but I think, as I alluded to at the beginning, if we don't regulate ourselves, someone is going to start regulating us. And so how much time are we willing to start doing this ourselves so that someone doesn't start imposing something that takes a heck of a lot longer? So we'll just finish up here. Just in summary, synoptic reporting, I think, has many benefits over narrative reporting. It's on its way into BC over the next 5 years with the help of some of the urologists, particularly Dr. Black is involved in that. The job is to achieve maximal buy-in from the surgeons here, as well as pathologists. And the idea would be to give focused feedback that can improve education, improve patient outcomes. And just to remember the trifecta, and that we want to be our own critic. Because as I said, it's better to be at the table than to have someone else policing us. But all in all, just remember, you're awesome.
Okay.
Thank you.
Well done. So